So good morning, everyone. I'm Lisa David, the President and CEO of Public Health Solutions, and we are so delighted that you have joined us today for this second session of our multi-part symposium series on integrating human services and clinical services with clients at the center. We have a terrific group of truly multi-sector participants today. We also have a small group of Public Health Solutions staff who are joining both to support the smooth running of our discussions and to listen and learn as well. So in our first session, the last session, we laid out the biggest challenges in coordinating health and human services delivery. We have a wonderful summary of that. If you weren't part of the first symposium, I highly recommend that you look at that. It's very robust. Today, we are going to be looking at digging deeper into solutions that are already in place on the ground, 3 local and city level models that have integrated healthcare and social services to positively affect the social to positively affect service provision to improve the social determinants of health and improve the health of communities. And what our goal today is to draw out the successes and challenges from each of these models and ways in which the lessons learned can help us design a strong framework for New York City. One thing to note, I just want to tell you all up front that we are recording almost all of this session so that we can capture those top line discussion points and share that back like we did in the first symposium summary with all of you. So most of you have known and worked with Public Health Solutions closely for many years, but let me start with a quick introduction for those of you who have not known us quite as long. All the work that we do in our vision is to improve health equity for all New Yorkers. And we pursue that vision with 3 approaches. First, we provide direct services in all 5 boroughs of New York City, all in high need communities. Second, we play an administrative role partnering with the Department of Health in New York City to establish funding accountability around grants to hundreds of community-based and healthcare organizations tackling major public health issues across all 5 boroughs. And then finally, drawing both of those areas of expertise together in the last few years, we have started to form and manage community-based networks of service organizations and connecting them to healthcare organizations and individual community members, as well as payers. So, as we all know, the pandemic has had a huge impact on the operations of everyone within the health landscape. Both the healthcare system and the social services system in the United States has substantially changed. And so this is really a crossroad moment for transformation. We see deepening food insecurity, increased housing instability, pretty slow job recovery, and the replacement of many in-person services in health with telehealth or remote services. And the need for a truly collaborative solution is greater than ever, and that's really been raised during the pandemic. We need a solution that provides a sustainable, coordinated, and indeed integrated approach to delivering holistic care. This requires centering the system design around a person's holistic needs and implementing the technologies and processes to provide needed communications, delivery models, data collection and sharing in order to really drive and change impact. In our first session of the symposium, we identified key challenges that lie in our path towards creating such a system of care. And while that list is much more robust than what I'm going to give you in this summary, and I again encourage you to go back and look at it, the driving themes were the lack of a closed loop referral system. And I just want to say that term means so many things to different people. I think of it as if you're a clinician ordering a lab test, You don't really care if it got to the lab or if they're doing the test. You need the results. We need to have the results in the same way around the social services that are being provided. A fragmented and siloed care system, which based on sort of the myriad of data and technology requirements of individual programs, actually prevents the exchange of data and information to be used in a meaningful way to improve health. And substantial issues around data collection, comprehensiveness, actionability, and making sure that we're compliant with security and privacy rules. A huge morass of challenges there. So those were the kind of issues we wanted to take into these discussions today. I want to mention we have 3 models we're going to present. We did look at a variety of other models, including larger statewide social determinant of health models, such as those in California, Oregon, North Carolina, in preparation for today's session. And we do have some findings from those, which are interesting, but we really wanted to focus on drawing out the learnings for the models that are really serving more diverse populations and complex needs that more closely mirror the work we are all doing in New York City. And so I will say for a moment, I just think the complexity in New York City obviously adds a level of challenge in coming up with a solution. We have 8.3 million people speaking over 600 languages, with over 62 hospitals just in New York City and 35,000 nonprofit organizations. Not to mention both the city and a state Department of Health, which are not always working smoothly together. So the level of complexity in New York is high. We're not going to consider that today, but we do need to sort of keep that in the back of our mind as we're thinking about what's worked and not worked in other models. So our objective at the end of the symposium is to use the best practice learnings from the discussions today to help design a solution that will help us deliver health and human services more comprehensively and sustainably in New York City. And that will be the topic of the 3rd symposium. So let me just walk through how it's going to work today. We're going to have an overview presentation around a theory of change, and then we're going to have 3 presentations from the 3 different models that we're looking at. We're going to do deep dives into each of those models in workout groups and come back and try and share the lessons learned. So let's start with the overall theory of change, and we'll go first to the cross-sector alignment theory of change model, which was developed by the Robert Wood Johnson Foundation and the Georgia Health Policy Center. It does provide a framework for public health, healthcare, and social service organizations collaborating to improve health, including factors that may lead to sustainability and long-lasting change from these partnerships. To present, we are lucky to have Karen Minyard, CEO at Georgia Health Policy Center. So I'm going to turn it over to you, Karen. Take us away.
Thank you so much, Lisa. I'm really happy to be here with you today. And I loved what you said, Lisa, about the complexity of New York City. And when I think about what you described with the 8 million people and all of the languages and the different boroughs, I was thinking, okay, this is not going to be a one-size-fits-all solution. And I was imagining as I was studying the 3 models that you're going to hear about today and looking at this framework, that what you end up designing over the course of your sessions is probably going to be something that is as complex in some ways as your situation, and that it will probably need to be tailored to meet different parts of the community. So I think it's exciting that you're going on this learning journey. And I think that you're going to hear things from each of the models that you hear today that are going to be things that you can use in your work. So I'm going to just say a little bit about this framework for aligning sectors. This is a framework that has been developed in partnership with the Robert Wood Johnson Foundation, along with the Georgia Health Policy Center. And we've studied the literature, we've commissioned research, we've talked to hundreds of stakeholders to try to think about, so how does all this work? And what we're trying to do is get to the place where there's this shared progress toward the community goals and needs, health equity, and racial equity. And this matches with the goals of each of the programs you're going to hear about, and it matches with what's going on in New York City. Now, one of the things that we identified is that the changes in mindset and practice and policy are important components that lead into these outcomes. And so one of the things that we're always thinking about is, how is the mindset changed? How is the policy, and how is the practice changed? I really like the central box of this model, and this has a lot of information in a small amount of space. So when we first started with this, we just had these cogs of shared purpose, data, governance, and financing, and how those things come together to help public health, healthcare, and social services integrate to get to these outcomes for communities. And what we found in the course of the last 2 years in our study across all of these different conversations and research was that it was more complex than these more technical things of shared purpose, data, governance, and financing, that there were some dynamic, adaptive factors such as community voices, equity, power dynamics, and trust that play into and are intertwined with these core components of the model. So in each of these examples that you're looking at, you have public health, healthcare, and social services trying to get toward this end of community health, health equity, and racial equity. And how do they get there? And this is a model that gives some hints. And if you think about the Camden Coalition, one of the big components of the beginning of the Camden's core model was data. They started looking at the data from the healthcare system about people who were high utilizers of the health system. And then they began to reach out to them with personal and social services to try to help think about what might happen. And so that cog was really the cog that got going first for them. And if you were to ask me from some of the conversations that we've had in preparation for this conference, I think probably data, and you mentioned it, Lisa, when you said, talked about people wanting the results. The data management, getting the right information to the right person at the right time is a central and important component. And it was a founding component of the Camden model. And these other things of community voice and trust and power dynamics and how the program would be set up and funded and what the purpose would be have also been intertwined in that. Take the 211 model in San Diego, another example of data being central. How do they put together the information and the communications so that people can have what they need? I haven't actually talked to the folks at San Diego about this, but I've been following their model throughout the pandemic. And it looks like one of the things that they did was even put more information related to the pandemic into their shared information so that they could rapidly take care of the COVID needs in their community. So their work is surrounded or founded or built on data, but there's also how do they pay for it? How is it governed? and looking at their shared purpose. And they emphasize their shared purpose of the community by pivoting quickly during the pandemic. And community voice, equity, power dynamics, and trust are also important for them. The Pathways Hub is a model that I have known about for more than 20 years. And so it is a favorite of mine. And part of the reason why I like it is because the work that is done is monetized and codified in ways that make it easier to get reimbursement, particularly from Medicaid or Medicaid managed care. It also helps to organize and make sustainable the work of community health workers, because when their work is monetized and codified and they are paid for performance, then it creates a stable environment. So I like this model because they have this financing component, they have a governance component, there's a shared purpose of meeting people's needs in the community, particularly people who are high risk. And also core to this model is data, because you need to be able to have the data to coordinate across different caregivers and make sure that you can monitor the output of what you're doing in order to receive the funding reimbursements. So each of these models has all of these components. And I would say each of these models have the component of how do we have the data capacity that's needed in order to implement this. And like I said in the beginning, I think that data capacity might be important and complex because of the complex needs. And maybe there's some aspects of each of these models and the others that were studied that will be what you decide to do for your next phase of work in New York City. So now I'll turn it back to you to hear about the models.
Thank you so much, Karen. It's wonderful to hear you talk through the model and to think through the pieces that relate strongly to the three models that we're going to look at. So now let's dive into those. First up, we have Tandem Coalition of Healthcare Providers, which provides care to people with complex health and social needs in Camden, New Jersey. To present, we have Kathleen Noonan, CEO, and Jason Torrey, Director of Field Building. So let me turn it over to you, and thank you for coming.
Thank you, Lisa, and thank you, Karen. So I'm Jason from the Coalition. I'm joined by Kathleen, our CEO. We're going to do a co-presentation. I'm going to kick us off here. Just want to say thank you for the opportunity to present, and just recognizing such a great group that we're here with. So we can roll to the next slide, please. Okay, so I want to acknowledge the really deep privilege in doing this work with the communities that we're serving and the staff that are doing it. You'll see their pictures and you'll hear their stories, and they really directly inform what we're doing and why we do it. So fundamentally, we're really grounded in the communities that we serve. And in the individual needs that we work with people every day to help them meet. So we see ourselves focusing more and more, certainly locally in Camden, specifically looking at individuals with complex needs, but also systemically. What are the root causes of those needs, and how can we build systems and ecosystems that can better serve the populations we're allied with? So next slide, please. And Karen set us up well when we start thinking about the data, but I want to offer a different perspective here. A lot of times in this kind of aggregated data here, and certainly we're known for this cost curve, and this is something that's consistent across the healthcare industry. The small group of patients that account for a significant amount of costs. But when you look more closely into that 1%, that is a diverse group, and it spans the lifespan. That's complex kids and families. adolescents that are struggling maybe with a chronic condition and maintaining school. Those are adults struggling with chronic conditions or behavioral health or substance use issues, and even frail elderly that are trying to age in place but are struggling, right? So in that 1%, and these are the groups that we focus on, there is diversity, complexity, there is individualized need that we work with every day to try to meet. And it is a privilege in doing so. So next slide, please. So I want to walk you through our model, and starting with daily triage, and we'll go clockwise here: bedside engagement, care planning, and community visits. So as Karen mentioned, we start with the data. So here's Molly triaging daily in our community around events, around acute events. So who's visiting the emergency room? Who has been admitted for an issue? So she has our health information exchange up. She also has the hospital electronic health record up. She also has our record, internal records up to see what is going on with this population. Where can we potentially intervene? Okay, so there's a manual, certainly a manual component here to this, but we're looking for trends, right? So not everyone would move to a bedside engagement. For example, if we saw someone that was recently admitted, and we look in the hospital record, and it turns out, okay, well, this family, their loved one was connected to hospice, for example. We think, okay, that's a great outcome. All right, that they're in the appropriate level of care where there's no need to intervene. But maybe we see someone who has been admitted now twice in the last 3 months for uncontrolled diabetes. And there's a social work note in there talking about lack of significant supports in the family and some recent traumatic events. So for us, we would put them into a bucket of, okay, maybe there's room to engage here. So we would then either contact the local, we would contact social work and case management within the hospital. And if we got the green light, we would go over and engage. So I'll walk you through what that kind of looks like. And you can see one of our engagement specialists here, Margarita, engaging someone directly at the bedside. Certainly it doesn't always have to happen in the hospital, but we see this as a teachable moment, right? So here's Margarita talking to a participant and really eliciting from that person, what's going on? What brought you in here? Can we help you? We then move through care planning if someone is agreeable, and then identifying needs. And then we're flexible to move through the community as needed, wherever an individual happens to be. So just really quick overview of that. I know we're gonna have breakout sessions to jump further into it, and I wanna give time for Kathleen. So next slide, please. And when we do work with folks, I often say, if you don't see it on here, think about the other bucket, because then we can fit it into there. So the idea of flexing individually, right, to needs, no matter where they are, right? And I often say this is helping make appointments to everything to repatriating someone's remains to their native country. So, and linking to other services that can help them meet those needs. I'm gonna pass this over to Kathleen to talk about some of the evaluations we've embarked upon, especially our RCT. Kathleen, take it away. Next slide, please.
Great. Hi, everyone. So thanks, Jason. So, and we should say that with our adaptations, our triage today is including a lot of focus on behavioral health, and we can talk about that in one of the breakouts. But in 2014, we formed a research partnership with MIT, JPAL, to test our theory of change and to contribute to the evidence base. We had an opportunity to do a randomized control trial, which I spent 10 years at Children's Hospital of Philadelphia, almost 8 in the research center. And for a small organization like ours to be able to do an RCT was really, it's sort of incredible. And we're continuing to sort of contribute to the evidence base. So next slide. So the question that we looked at in 3 years between 2014 and 2017 was, at 180 days after hospital discharge, do patients enrolled in the Camden Core model experience a lower rate of hospital readmission? And if you move to the next slide, big takeaway is that the care management alone can't remedy lifetimes of complexity. We need a broader ecosystem to change some of the things that we saw and multifaceted measures of success. And I'll just say that what we found, just to be clear, is that the control group and the intervention group had the same level of hospital readmission after 180 days. Interestingly, this hasn't actually received a lot of pickup, but it's really important for this group. There was a statistically significant difference for the intervention group in terms of connection to SNAP benefits, which is really, really important. And a big takeaway for us is that we're talking about patients with incredible complexity who had been in the hospital at least 2 times in the last 6 months. And the fact that we found so many of them not connected to SNAP, even though they were eligible, is something for us all to really, really think about. So next slide. Some of the next steps that we're working on are really focused on understanding and continuing to build the ecosystem that Jason talked about. And we will be publishing manuscripts on this, doing CQI studies on whether dosage made a difference, dosage of our intervention. Housing impact. We were able to stand up a housing program 2 years into the intervention. So was there a difference for people who were able to get a housing intervention? We'll look a lot at patient segmentation and then also adaptation since our intervention, since the intervention period was closed under the RCT. There you see one of our MLP lawyers. We've actually embedded them into our teams now. And we are working on issues that most medical legal partnerships won't work on, that we think are critical to our clients' stability, like fines and fees, where a civil fine can land them in jail because a bench warrant turns into criminal time. So other adaptations that we'll talk about include what we've done with Aunt Bertha since 2015 in terms of closed loop referrals, expanding our HIE to really include, not just be focused on healthcare, but social services, housing, and then recently the COVID pandemic has actually created the need, which we are very happy about, to bring our county health system onto our HIE. So Jason, let me just hand it back to you quickly to talk about a little bit more about how we're moving this forward. I'm sorry so fast, but we're trying to stay within our 10 minutes so we can give people time.
Okay, next slide, please. So I'd like you all to take a look at what our community advisors are saying from our community advisory board, right? And to Kathleen's point, thinking about ways of measuring our impact, certainly participant and provider experience is a important component. So we're listening, we're asking questions and listening on how to do this better, and taking that right from the folks that we're seeking to serve. So I think that's certainly an essential design component here, and core to our approach as an organization. Next slide, please. And we're working nationally. So our Camden Coalition of Healthcare Providers has a national initiative called the National Center for Complex Health and Social Needs. And we're doing similar work across the country, working with similar coalitions, collaborations of different types of organizations to focus on complex populations. So I'm looking forward to hearing the other presentations. I want to make sure we're mindful of time, and that's all we have, and looking forward to the breakout session. Thank you.
Thank you so much, Kathleen and Jason. I know it's unfair to try and convey decades of work in 10 minutes, but we will have a chance to dig into it a little bit more. I think Camden Coalition was the first organization that I ever became aware of social determinants of health with the prescriptions for food early in my career. So it's fascinating to see how far it's come. So next up, we have 211 San Diego, which was developed by the United Way in 1997. 211 San Diego began as a 24/7 information and referral helpline and has evolved into an organization that provides phone and web-based referrals, one-on-one coordination via a team of health navigators, CBOs, and health system partners to help at-risk patients. To present, we are honored to have Karis Grounds, VP of Health and Community Impact. Over to you, Karis.
Hi, good morning from the West Coast. All right, so yes, I'm Karis Grounds. I'm with 21 San Diego and the Community Information Exchange. So as Lisa kind of alluded to, we've been evolving over time. If you go to the first slide, and I'm going to try to keep it at 10 minutes too, so I'll go quickly. But traditionally, kind of 2-in-1s, you've heard of 2-in-1s, they're across the nation, either part of a United Way or, in our case, our own 501c3. But essentially, historically, we've been supporting kind of the coordination of a place to call to access health, community, and social service resources. In San Diego, we have a bunch of additional kind of escalated navigation-like services that we provide. But our role has been kind of a trusted resource within the community and kind of establish ourselves as a convener, backbone organization, and supporting collective impact. And 2-in-1s play that role in some cases. Every 2-in-1's a little bit different, but just so you guys know, 2-in-1 is kind of the infrastructure in which we operated out of. And so about almost 10 years now, we started what we call the Community Information Exchange. And that was built out of our local community, looking at maybe a similar story to the Camden Coalition, but there was a bunch of, seeing our homeless needs within our local community and being transported via EMS to the hospital, to the same shelters, and there was no coordination among these people. And so kind of key stakeholders within the community said, like, hey, what if we started sharing information? What would that look like? And could people consent to have their information shared? And that's really where the Community Information Exchange evolved. And it's been evolving over time. And I think to Lisa's point, and maybe with Camden too, it's like there's been this huge emphasis on how do you connect SDOHs, or what does it mean to do SDOH work? And so I think we've probably all been doing SDOH work for if you're a social worker or a public health person, that's kind of the infrastructure in which you've always operated. But there's been this new connection around data. And so really ours is currently a network of over 100 organizations sharing data through an integrated system. So it's an integrated platform that you can either log into one source and log into a system, or it can be integrated into your existing platform to be able to better coordinate care. And so if you go to the next slide, the goal of this really is meant to be person-centered care. So I think what's unique about our model is that it's not meant to be about data, really. I don't know if that was our end all intention, that's what's happening now, but I think it was really about how do you connect these siloed systems and start putting the person at the center. And instead of requiring this individual from individual level, repeating their story over and over again, could by sharing this information or working better together, could interventions change from a meso level across organizations, across agencies, to be able to better support that individual? And then from a macro level, could we use that information to better enforce our policies or infrastructure within our communities to support them? So it was really meant from it started from an individual level, and now it's kind of radiating out, but we built an infrastructure or system that allows for us to do referral management, care coordination, and data analytics all in the same platform. So if you go to the next slide, this is kind of what a CIE is. So we have like core components. We've published a toolkit that kind of is being leveraged. And so really we've focused on the core components, but I think what might have gotten missed in this 500-page manifesto that we put together is what it really is. There has to be these tenants and a community-led steward infrastructure for it to be successful. And sometimes these we've learned, we have a lot of lessons learned, we have a lot of failures through our process. We are still figuring this out, but we know that if we can center the person, and that if we're built through an equity and anti-racist framework, and that we're including community voice and leading with the experts, which are, in collaboration with healthcare, social services, but really leveraging the community to help us inform how we're approaching this, it could be sustainable and maybe not financially yet sustainable, but sustainable as an infrastructure to be leveraged across initiatives. So if you build this right, you can leverage this for any food insecurity, housing, any social need that kind of comes into the space, or new initiative, or new Medicaid transformation, policy. If you have a good infrastructure, you can leverage this for kind of all things. So we go to the next slide. This is a little bit about our community-driven approach. So again, we have a community stewardship. This is what I think becomes unique and why people across the nation, I think, are looking at our model is because we're built within a community leadership. I think we started with a community governance structure that allowed for a place to decide how we were going to use the data, how we were going to be informed by community needs. It's owned by the community, so it's really an opt-in model. It allows for community access and input through our advisory board. We want to make sure we're representing the community and small community-based organizations within our community. It's tailored by the community, so meaning that we customize, we have control over that system or infrastructure, how the data is being collected. And then it's integrated. We are not one size fits all. We're not using one. We have a shared system people can access, but that's not our assumption. We integrate data from our homeless management system, our food bank, our CBOs that are providing these services. So the expectation isn't that everyone adopts the same infrastructure, but is there some standards that we can create across our system to be able to allow for it to be integrated, for it to be leveraged, not duplicate documentation in multiple systems. We go to the next slide. These are some of the core components. So again, that network of partners. And when I say shared language, that's these 100 organizations. We have shared kind of values. You know, when you join the network, there's some intentional elements that we've put into place. So that governance really decides it, but there's shared agreements that we all leverage and use, and authorization that we use, but we also create joint authorizations with other existing multi-party agreements in our HMIS system, or at the, when you do an intake at a food bank, you can also consent it to CIE. So we've embedded it into the infrastructure where people are actually accessing services. So we want to meet clients and organizations where they're at. The shared language isn't saying that we all are using the same tools, but really that can we create some standards across the system to create some language that allows for us to be able to communicate. Bidirectional closed loop referrals, I think that's an overemphasis. I mean, we of course, this is a use case of it being able to connect health and social services, but our goal is really to change the way that we provide care. So it's really a systems change effort, and referrals are a component of that, but not the end game. And I think everyone could probably agree to that. Like, referrals become a use case for being able to make those connections, but eventually we want community care planning. And that's kind of where we're ending with through the technology platform and integration. We can actually have a longitudinal record that we're collaborating and working in a more person-centered way to provide the best to our clients within our community. I'm going to quickly try to go as fast as I can through the other probably 5 slides I have. So this is just a little example of what it looks like in our shared record system. But there's anything from client data sources to care team members to program enrollments to history of referrals. And so we share this information. Of course, people have different role-based permissions. I'm sure everyone's thinking about legal, security, all those kind of things. So we have different ways to people can access, can view information within the system. But again, it's information with the intention of changing your intervention based on the information that's in there. Like, are you going to refer to the same program since you already see that they're referred, or they're already enrolled with this homeless provider? Can a hospital discharge planning connect to that organization instead of discharging them to the street? Those kind of things. And if you keep continuing on, here's some just examples of what primary care use is. I kind of alluded to some of them just a second ago, but searching for patients or members to see their historical use of social services, making referrals to external programs, screening or prioritizing resources, prioritization of resources. We've seen this a lot with like ACEs and adverse childhood experiences and the homeless prevention resources. Can organizations come together and leverage our tool to do shared screening or prioritization of resources, or better coordinate access through the system? And then also this idea of proactive response. If we can receive alerts if someone's been transported by EMS or other instances, to be able to provide a more comprehensive care. So if we go to the last slide, I'll just quickly go through, I think this is the last slide, but this is basically a little example of how we've looked at outputs, outcomes, impact. Again, this is just a new field. So we're really moving just from outputs into outcomes, and how do we measure that? I think we've seen some initial studies you can look back on where we've seen some outcomes and being able to say small cost savings. But again, when you overemphasize on cost savings, I think there's sometimes you're missing the point a little bit, right? Because this is really about addressing inequities, changing well-being, I think addressing health indicators, but really the long-term is really improving the individual's state of being and moving systems change, I think is our primary goal, and being able to see if we can change the way that we provide care in a more comprehensive way. I think that's my last slide. Yes, thank you. I did it.
I gotta say, all of you are amazing in being able to present a lot of information within 10 minutes. And how seriously you've taken it, we really appreciate it. This is incredibly impressive. Thank you, Karis. The sort of comprehensive and systemic way that you have approached this is fascinating. And we definitely want to learn more about it. So thank you, thank you. And finally, our third model for review is the Pathways Community Hub Institute. The hub model is a delivery system that provides a unique strategy to supplement healthcare services with social services needed to overcome the barriers for those at risk of poor health outcomes. And to let you know, it's also in action in several states, including Ohio, Michigan, Wisconsin, Washington, Texas, and there are more states on the way. So to present, we are grateful and honored to have one of the co-founders and executive director, Sarah Redding, and co-founder and director of research quality, Mark Redding. So Reddings.
Yeah, we're interchangeable. That's okay.
Well, thank you. I'll bet it is a bit.
And I left Mark just one slide at the end, so you will get to see him. So thank you so much for inviting us. It's really an honor, and I want to be in the breakout groups to learn more about the other models. So I'm glad you're recording all of this, but I'm going to do the whirlwind view of the Pathways Community Hub. So let's go to the next slide. And I just put in, this is our website, the Pathways Community Hub Institute website. So anything I talk about today or that Mark talks about, you can find it on the website. So you can see a map of where hubs are. You can connect with hub directors. You can see our research publications. It's just pchi-hub.com. So the next slide is a visual of the Pathways Community Hub model. I'm going to show you this and then kind of break out the parts and come back and show you the slide again. So this model is really, it's not a program, it's a way to provide transformational change within a community. And to do that, the one thing you have to put in place is the Pathways Community Hub, but that's a fairly small addition to the community. What the hub leverages is the organizations that are already in place. So who are those community-based organizations that are providing care in the community now? So it's really looking at how do we do things more efficiently and effectively and do it in a sustainable way so that we can build a workforce and support that workforce. So I'm going to come back to this slide, but let's go to the next slide and talk a little bit about the Pathways Community Hub itself. So this organization, this hub, is neutral, it's transparent and accountable. It does not do the community-based care coordination work. It partners with others in the community to do that work. There's only one in a community or region. So again, if we had multiple hubs, we'd have just bigger silos. That's not what we want, just one in a region. And the Pathways Community Hub uses outcome-based contracting, and I'll talk about that a little bit, but we're really driven by not just identifying that there's needs, but making sure that we resolve those issues that people face. And if there's a theme that I'm hearing through all the models, it's person-centered, you know, that we're all focused on what's best for the person, that's not what's best for the agencies or organizations. We also have a community advisory council. That's a requirement. And that advisory council really needs to be made up of stakeholders from a wide swath of the community, including community members. And the Pathways Community Hub agrees to use standard data collection tools. So the hubs in Ohio and the hubs in Washington State are all using the same standard pathways and the same data model. The next slide talks a little bit more about our certification approach. So one function of the Pathways Community Hub Institute is to certify Pathways Community Hubs. And so these are some of the areas that are looked at in the prerequisites and standards that a hub must meet. So their ability to convene, to bring very diverse partners together and to work together collaboratively. Training, there's a huge workforce development component to this model. We need those community health workers and community-based care coordinators to actually make this model work. Contracting, so the ability to develop contracts that are outcome-based with agency partners, but also with a variety of funders. Governance, I mentioned the Community Advisory Council. Quality improvement is critical to this model. It's an ongoing look at what's working and what's not working, again, using the data that's gathered. Technology, most of the hubs are using a technology platform. Evaluation and research, both at the local hub level, but also at the national level, and Mark will touch a little bit on that. The next slide, I often get asked who can be a hub, and it really depends on the community or the region. So I'll start with who can't be a hub, and that's really anybody in the healthcare system. So a hospital can't be a hub, and a payer can't be a hub, and a clinically integrated network. This is not healthcare system-based care coordination, which is very important. This is community-based care coordination. So they're not appropriate to be the lead on this model. So most of our hubs live in community-based organizations. The original hub, Community Health Access Project. We have hubs that have developed in community action agencies and a health department in United Way. We also have several hubs that have developed in community collaboratives or hospital associations. And we have a few hubs out in Washington State that have developed within accountable communities of health. So just to kind of give you a range of what hubs look like across the country. The next slide gets into those care coordination agencies or CCAs. Again, the pretty small hub contracts with existing agencies already in the community. We call them CCAs. That's where community health workers are employed. That's where their supervisors live. The hub and the agency contract and have agreements that the agency will use the standard data collection tools. They agree to the outcome-based payments and the concept of not only whole person care, but whole family care. That if a community health worker or community-based care coordinator forms a relationship with an individual at risk, that they also will agree to take care of other family members that may be at risk as well. The next slide really points out that the key to all of this working is the trusting relationship that the community health workers can build, plus the accountabilities of pathways. We really feel those two things are critical within this model to make it work. The next slide focuses on funders. That's a key because we have to build sustainability. So, in this Pathways Community Hub approach, 50% of contracts are directly tied to pathways or confirming. One way to think about that, if a risk is identified, it's resolved, and that equals payment. And so Pathways Community Hubs have built contracts with health plans, with health systems through community benefit dollars, through local, state, and federal agencies, through grants, through private philanthropy, United Way. There's a whole variety of ways that hubs bring in funding to support the network that they've built. In Ohio, where we now have 11 hubs, soon to be 13, all 5 Medicaid managed care plans contract with those Pathway Community Hubs around pathway completion. And there's even language in the Department of Medicaid contracts with the plans that if there's a hub, they need to contract with them. So that's where we're trying to move other states that are deploying this model. The next slide just brings it all back together. So again, the hub in the center, small neutral organization that's really playing the air traffic control function of connecting all of those care coordination agencies together that are using the same data collection strategies and going out and finding funding that will be sustainable over the long term. But at the core of everything is protecting that relationship that the community health worker is building with the person or family that they're serving. We don't want to disrupt that in this model. The next slide gives you a little bit of sense of the actual workflow. So a community health worker, once they engage with a community member, would do an assessment of risk and all risk, whether it's health risk or food or, legal issues, all of that is assessed. If a risk is identified, a pathway is assigned. And again, a pathway ends in a measurable outcome. And because we're using the same measurement strategy, we can see how individual community health workers are doing, how agencies are doing, and how hubs are doing. And we can offer to come in if there's struggles or highlight them as best practice to other communities. The next slide gives you a little sense of those 21 standard pathways. Again, these don't change across the hubs. We measure things the same way. A few pathways, we have multiple codes to track what's happening to just make it easier for the CHW. And the next slide gives you a visual actually this highlights a little bit of what some of those outcomes look like. So for example, with adult education, if somebody is on an adult education pathway, the pathway doesn't close until whatever educational goal they set, whether it's completing their GED or completing a semester of college, that it's been confirmed that that has been met. The next slide shows the medical referral pathway. So this just gives you a paper visual version of what a pathway looks like. And this is one example of where we have many different codes within the pathway, because from a community health worker or care coordinator's perspective, the process is the same. If somebody needs connection to a healthcare appointment, they're going to go through the same process, whether it's an appointment for dental care or to set up advanced directives. They need to understand why it's important. They need to make sure it's scheduled. All barriers to getting to that appointment need to be removed. And then confirming that they actually kept that appointment and they were able to resolve whatever the issue was. The next slide highlights our learning pathway. And this is how we track individual education that's provided between the community health worker and their participant. And I highlighted two of our more current learning modules that go with these pathways around vaccine hesitancy and respiratory viruses. But really, we recognize that at least a third of risks are related to knowledge and education and understanding what the risk really is. So we have developed, over 50 plus learning modules now that directly address risk factors. The next slide talks a little bit about our outcome-based contracting. So each one of those pathways has a unique code and modifier. So when we do develop contracts with a health plan, we're speaking the same language. So that helps them in going through the invoicing process. But we've also assigned an outcome-based unit. And what that does is identify the higher risk issues plus how long it takes on average to complete one of those pathways. So clearly getting somebody into safe, stable housing for 30 days from their move-in date takes a lot of effort, and that's recognized with a higher OBU value. So as contracts are developed, it's really figuring out how much is one outcome-based unit worth, and then you can populate in the rest of the contract. So from certification from Pathways Community Hub Institute, again, we require that 50% of contracts are directly tied to confirming that people have had their risks resolved. The next slide is this is a busy slide. So, and I'm checking my time. We're getting close to the end here, but it just kind of walks you through how contracting works. So over at the right, you see I've listed 4 pathways: housing, mental health, healthcare coverage, medical home, what their outcomes are, what their outcome-based units are. If we go over to the left side of the slide now, we see that pink bar at the bottom, that's the local hub. And the hub hub negotiates with health plans, hospitals, government entities to build contracts that if their member or a particular population has a completed, we're taking housing pathway here, that they will pay $50 for each outcome-based unit. 50 times 15 is $750. So the hub would invoice for that amount, and then they would turn around and pay the care coordination agency that actually employs the community health worker. So it's just kind of giving you a visual of how that functions. The hub usually retains a percentage because they're doing all the invoicing, the reporting, the quality improvement, maintaining the technology platform. So a percentage is retained at the hub. So the next slide, I'm going to turn over to Mark to just touch on research and what's happening in New York now. I think you're muted. So maybe I will finish this last slide because it looks like Mark's having technical issues. This is just showing some of the research. And again, you can go back to the website to find publications around the model. But our original research on the right was done by Community Health Access Project, which was the first program to adopt Pathways and then the first Pathways community hub in the country. And what we were able to show with the research was that we could decrease low birth weight almost 60% by implementing the Pathways approach. And the interesting thing when we really, looked at the women that were engaged, most of their pathways, again, their risks were not health. Majority were around employment, adult education, smoking, food security, housing, what we would all expect. But there was really no difference between our intervention group and our control group as far as access to care. We were looking at high-risk pregnant women, so access to prenatal care or utilization of care. So again, emphasizing the importance of the social determinants of health. On the left side of the slide is actually a study that was done by one of our managed care partners in Ohio a few years back. Centene or Buckeye Health Plan in Ohio looked at 3,700 deliveries in our hub based in Toledo, Ohio. And they were able to show a 236% return on investment for those members if the moms were engaged with the CHW through the Pathways Community Hub. And if they looked at the high-risk moms, that was over 400% return on investment. They also could see that if they had, similar high-risk moms, if a mom wasn't enrolled and engaged with the Pathways Community Hub, she was more likely to have a baby that ended up in the neonatal intensive care unit. So again, looking from a very different lens, the health plan was seeing improvement in outcomes and cost savings. So I will close here. I know I've probably gone over time, but I do want to mention that we are doing some work in New York. So we have been working closely with Ngozi Moses with the Brooklyn Perinatal Network, which is a fabulous group. We're also doing some work with other potential hubs in central New York, so there's other work happening in your state. So just wanted to stop there and really looking forward to the breakout.
Thank you, Sarah. And it's been incredibly interesting to see at a high level the overview of these three different models and sort of range of information from sort of how you characterize the patients and the needs and how you deal with the data exchange and fascinatingly actually how you fund this and what the outcomes can be. So I'm really looking forward to hearing more from our breakout sessions where we'll delve a little deeper into each of these three. But before we do that, I want to give some thanks to the advisory committee, who has had an incredible role in helping us make sure that these symposia are, fruitful and interesting and learning opportunities. So the committee consists of Patty Buzang, who's the Senior Managing Director of Manat Health, Manat Health and Phillips, LLP. Dr. Ayman Mohandes, who's Dean of the CUNY Graduate School of Public Health and Health Policy and a board member. Diana Mason, who's Senior Policy Service Professor at GW University School of Nursing and a board member. Erin McDonald, Regional Administrator, Agency for Children and Families, U.S. Department of Health and Human Services. Tanya Shah, an advisor for Prospero Health and a board member. And Dr. Abigail Velikov, who's the Senior Director of Child and Family Resilience and Innovative Partnerships, the Division of Family and Child Health at the New York City Department of Health and Mental Hygiene. They have been extraordinary contributors and have really been key to shaping productive meetings. And the three board members, Dr. Ayman El-Mohandes, Diana Mason, and Tanya Shah, will be moderators for the breakout sections. So each breakout group will be delving further into one of the three models that we've heard of. And the three topics we would like every group to consider so that we can look at some information across all models are: what are the key design elements to create a robust and engaged network of organizations? What are the operational approaches for outreach and service coordination and quality improvement that will support scale, improvements in equity in the people served, and demonstrable results? And then third, what data standardization and technology requirements are required to provide effective services, but also to coordinate and measure the impact? So each of you has already been assigned to one of those groups. We wanted to ensure diversity of perspective, so we've tried to make sure we have community-based organizations, healthcare, managed care players in each group. You will also have PHA staff in these sessions. The sessions are going to last 1 hour, and we encourage each group, and you'll have a PHS staff person that will help sort of gather some of this information as the discussions are going on, to summarize. If you could save 10 minutes to summarize sort of the key findings that you would share out during the report out around what were the things that really worked well and made this model successful, and what are the key challenges that either were addressed or may still need to be addressed, so that we can take those sort of top line outcomes. We definitely also will, from the recordings, have the much deeper conversational information to be able to do a summary for everybody of all three groups. And of course, the recordings are available to all of you. So in a moment, you're going to see a pop-up inviting you to your group. I think you only have to press join. And if you have any issues, which means you'd be left in the main room, Kate Birdsall will shepherd you into a breakout group. So thank you and have a great discussion.